This short presentation is about the disease of rheumatoid arthritis. If you want to go through anything that you don't understand on this presentation, please do let me know, and I'm happy to do so. And here are my contact details if you need them. Rheumatology is an umbrella term which covers a lot of pathologies. We've got inflammatory joint diseases such as monoarthritis, where one joint is infected, for example. We've got things such as gout, where crystals are deposited inside a joint. We've got some of the autoimmune soft tissue type diseases such as rheumatoid arthritis, polymyalgia rheumatica, psoriatic arthropathy, and SLE or lupus, which is systemic lupus erythematosus. It also includes things like ankylosing spondylitis, OA, fibromyalgia, and bone disorders as well. It's important to remember that rheumatoid arthritis is actually rheumatoid disease. It's an autoimmune disease that affects collagen. It just so happens that from the physiotherapy point of view, the greatest manifestations are musculoskeletal. So this is what rheumatoid arthritis can do to a joint. We get a massive amount of inflammation inside a joint, which can cause damage and subsequent erosion to the joint and the soft tissues. Unfortunately, there's no silver bullet that will diagnose rheumatoid arthritis, so we have to rely on a collection of indicators and outcome measures. In 2010, the ACR and EULAR rheumatoid arthritis classification criteria are introduced, and these replace the old ACR, American College of Rheumatology criteria of 1987, and it talks about a point system. So if you have a points total of 6 or higher, you have rheumatoid arthritis. Rheumatoid arthritis is a relatively common disease, and it's certainly been around since medieval times. The term rheumatoid arthritis was first coined by Garrow in 1859, and it's got an incidence of about 1 to 3% of the population and a prevalence of 0.5 to 1% of the population. People often get confused between incidence and prevalence. Just have a look at the differences. It does affect more females than males in roughly a 3-to-1 ratio, and the commonest age of onset is between the ages of 30 and 50. We don't know what causes it, but like with most diseases, there's a genetic component, there's an environmental component, and an occupational component. So we do know that smoking is a risk factor, but it's also much commoner in identical twins with a 30% concordance ratio and a 5% in non-identical. And genetically, 90% of people who have rheumatoid arthritis will have the same DR4, DR1 epitope. The pathology of rheumatoid arthritis is very complex. What happens is that we get activation of the immune system which goes off the scale, which can cause destruction of joints, hypertrophy of the synovium, the presence of T cells in the dermis, and a cytokine storm. In this diagram here, going from left to right, you'll notice this ACPA production. That's an anti-citrullinated protein antibody production. Basically what that means is that there is a change in the structure of one amino acid in the body, which is a very minor change, but the change is large enough for the body to recognize the new structure as an invader, and that's what sets off this inflammatory response. This graphic is to try and illustrate the latest thinking about the mechanisms of the cause of rheumatoid. What happens is that we get an influx of some invasion into a cell, which then stimulates the production of PAD. PAD stands for peptidylarginine deaminase, and that has the effect of causing citrullination, which is the change in this shape of an amino acid, and that causes the body to produce antibodies to this changed amino acid. So it's all about the change in the shape of a molecule that the body then recognizes as an invader, really. If we do blood tests on people with rheumatoid arthritis, almost all of them will have antibodies to anti-citrullonated proteins. And this is to try and illustrate the change in shape of a molecule from arginine to citrulline. Rheumatoid arthritis can start in many ways. It can start as an acute disease, it can follow a flu-like disease, or it can start very gradually, or it can begin with systemic features that affect the internal organs, for example. The symptoms of rheumatoid arthritis are many, and it can include joint pains, many joint pains, which is polyarthritis. Fatigue can be a major problem. Diffuse musculoskeletal pain, swelling of the joints, morning stiffness is a real feature of active rheumatoid arthritis, and functional loss. And it's important to remember that rheumatoid disease is a systemic disease, so basically any tissue with collagen can be affected by rheumatoid arthritis. This mnemonic might be useful, the mnemonic rheumatism. So the R stands for rheumatoid factor, which is basically an antibody test. H stands for HLA, DR1 and DR4, that's a test for a gene. E stands for ESR, or extra articular features. An ESR is a blood test, and what happens in an ESR is that you take blood from a patient and leave it in a test tube for an hour. If the blood is normal, you go back in an hour and the blood stays as blood. But if you have inflammation in the blood, the red blood cells become electrically charged, they stick together, they become heavy, and they sink to the bottom of the test tube. And the more red blood cells that sink to the bottom of the test tube, the greater your ESR. So it's not a test for rheumatoid, it's a test for inflammation. The U stands for ulnar deviation of the fingers, which is a common deformity. M stands for morning stiffness. A stands for atlantoaxial joint subluxation, which is a dislocation of the upper cervical vertebrae. T stands for T cells, which are present. I stands for inflammatory synovial tissue. And then S stands for a swan neck deformity, which is a finger deformity. And M stands for muscle wastage of the small muscles of the hand. When a person has an active flare-up of rheumatoid, the joints become very hot and swollen and tender to the touch. The person can develop anemia. They are usually rheumatoid positive, although you can have seronegative rheumatoid arthritis. The ESR will be raised, as will the CRP, which is C-reactive protein, which is an enzyme made in the liver. The end product of this can be deformity and instability in joints, and you can also get peri-articular features, which is features around the joint, and you can get non-articular features as well, so things that you might not expect. Rheumatoid arthritis can pretty much affect any joint. It can affect the hands and feet. In fact, it usually starts symmetrically and distally in the hands and the feet. It can affect the metacarpophalangeal joints and the proximal interphalangeal joints, the knees, the elbows, the ankles, the shoulders, the cervical spine, the jaw, the joints at the front of the throat, and it can even affect the joints in the ear and cause deafness. Strangely enough, the hip joint is quite often not too badly affected by rheumatoid. Because rheumatoid is a collagen disease, it affects other structures other than the joint. So these are known as extra articular features, and I've listed the main ones here. So malaise or general feeling of being unwell, a fever, myalgia, which is muscle pain. Anemia can either be caused by the disease itself, the loss of appetite and subsequent failure to eat because of the pain, or actually bleeding from the drugs that the person's being given. Felty Syndrome is something that can happen, which is a syndrome where the spleen becomes enlarged. Hemolysis can happen, that's where the red blood cells actually start to explode, really. You can get skin problems, you can get vasculitis. I've got some photographs to show you of that later. You can get nodules in the joints, usually on the extensor aspects of the joint. You can get rashes, either from the drugs or you can get a rash from the disease. You can get what's called a palmar erythema, which means that the palms of the hands go red. It can affect the eyes, it can make the eyes go very dry, and that can be a problem because it means that the cornea can become ulcerated, so the person may need synthetic tears. And it can affect the lungs, it can cause nodules, pleurisy, pleural effusion, or interstitial fibrosis. And the list goes on. So it can affect the heart, it can cause pericarditis, inflammation of the membrane around the heart. It can cause inflammation of the muscle of the heart or cardiomyopathy. It can cause valvular problems. And there is a correlation between accelerated atherosclerosis and rheumatoid arthritis. It can also affect the central nervous system. It can give you neuropathies. It can affect the nerve roots as they leave the neck in particular. And it can cause paralysis in severe cases. In the kidneys, you can get what's called amyloidosis, which is the deposition of a white protein deposit that can affect kidney function. It can affect the gastrointestinal system, either the drugs that are used for rheumatoid arthritis or the disease itself. It's quite difficult to predict who will do well or who won't do well, but these are some of the common parameters where people don't tend to do well post-diagnosis. So older onset, female, the more joints are affected, if the inflammation can't be kept under control, if there is structural damage or functional disability, if there are extra articular features, psychosocial problems will make things much worse. If the patient is seropositive and if they have this shared epitope HLA DR4, DR1, these factors tend to speak towards a poorer prognosis. As you learn about chronic disease, you'll realize that the pathway of a disease is difficult to predict. Rheumatoid arthritis tends to go through periods of exacerbation and remission, and this graph just shows you the radiograph changes, the purple line, so the X-ray damage. The disability tends to fall pretty closely to the X-ray damage, and then the inflammation can quite often settle down later, but by that time the damage is done. Rheumatoid arthritis can disappear and it can go into remission. So it's said to be in remission when the person has morning stiffness of less than 15 minutes, the joints aren't painful or tender, and there's no soft tissue swelling, and the ESR is less than 30 millimeters an hour for a female or less than 20 millimeters an hour for a male. The treatment of rheumatoid arthritis has been revolutionized with biologic drugs in the past sort of 20 years. We now treat rheumatoid arthritis more aggressively than we used to. We used to start people on very minor non-steroidal anti-inflammatory drugs such as ibuprofen, aspirin, naproxen, Voltarol, that kind of thing, and then progress to slightly stronger drugs and then end up with steroids. Now we tend to treat people much more aggressively. So a DMARD is a disease-modifying anti-rheumatic drug. An NSAID is a non-steroidal anti-inflammatory drug. Steroids can be useful. Steroids tend to have a bad reputation, but steroids are very good anti-inflammatories. And the new treatments include the biologic therapies, which are immunosuppressant and mop-up antibodies. A complex disease requires complex management, and the goals of treatment are to relieve pain and prevent deformity, to maintain function, to educate the patient about what they should and shouldn't be doing, to encourage exercise within limits, and to think about different professions and how they might be involved in the management of rheumatoid arthritis. So going back several years, we had this pyramid approach where we started at the bottom and worked up, and the pyramid's now been reversed. So as I said in the previous slide, we do tend to manage people with rheumatoid drug-wise more aggressively than we used to. You will come across some rather complex drugs in the management of rheumatoid arthritis, and I've just listed some of them here. Auranofin is a gold compound, so you might get patients that say that they are taking gold. Gold salts are thought to be anti-inflammatory. We have things like azathioprine, cyclosporin, cyclophosphamide, hydroxychloroquine, leflunomide, methotrexate, penicillamine, sulfasalazine. So some of these drugs are anti-inflammatory, some of them are immunosuppressant, and some of them are cytotoxic drugs. So there's quite a powerful cocktail of drugs at the disposal of a rheumatologist. Probably the greatest advance in the past 20 years has been the influx of anti-TNF medications. These are called biologic drugs. They tend to mop up antibodies and they can be extremely effective. They are immunosuppressants, so you have to be careful who you give them to. If you have a history of cancer or TB, you have to be very careful about what drugs you give. These immunosuppressant drugs have very strange names and they're rather expensive, although less expensive than they used to be since they've come off license. Some of them are every 2 weeks they have an injection, some of them the patients can do themselves, but they are very successful. I've just listed some of the potential adverse effects of the biologic drugs here. I've now got some photographs of what rheumatoid arthritis can do to a person. So the first one here is a sample of synovial fluid taken from an actively inflamed joint. Synovial fluid should be clear or straw coloured, and if you aspirate it from a normal joint, you should be able to read newspaper print through a test tube holding synovial fluid. But you can see here how this is blood stained. This is an MRI of a cervical spine in somebody with rheumatoid arthritis, and if you look you can see there's a little indentation where the spinal cord is being compressed right at the top. So C2 has a little peg called the odontoid, and you can actually see that because the skull and C1 have slipped forward slightly, C2 is now pressing on the spine. What can happen in rheumatoid arthritis is something called atlantoaxial instability. So this is C1 and C2 with the skull removed, and the pink-purple ligament here is something called a transverse ligament. That can become eroded in rheumatoid, so that means that when the head nods backwards and forwards, the spinal cord can be compressed, and that can cause paralysis and even death. So please, please, please don't ever manipulate a rheumatoid neck. This is an example of a cervical fusion that would need to be done in somebody with severe atlantoaxial instability. And this is an example of the immobilization after that surgery. The inflammation in rheumatoid arthritis can be immense. So this is a young girl who's got bilateral knee effusions, and in particular you can see on her right knee she's lost all contours and she's got a huge effusion of the right knee. You may see some severe deformities in the hands of people with rheumatoid arthritis. I used to work in rheumatology and it was quite distressing, but you realise after a while that because these deformities come on very gradually, people do adapt. So this is an example of severe rheumatoid arthritis. You can see how the fingers have subluxed off the metacarpals. You can see various deformities of the fingers, and you can see effusions of the wrist joint. And if you look at the x-ray that corresponds to it on the right, you can see that the carpal bones have all fused into one. Here's an example of a severe effusion in somebody with an active flare-up of rheumatoid arthritis in the knee. This photograph shows you vasculitis, and you can see how the tissues have died distally in this finger because of inflammation and occlusion of the small blood vessels going to the fingers. That can be a medical emergency that might need steroid intravenous administration. Again, you can see bilateral rheumatoid arthritis of the hands. You can see what's called a Z thumb. The thumb takes on a deformity that looks like a letter Z. You can see ulnar deviation of the fingers. You can see that the fingers have slipped off at the MCP joints, and you can actually see the heads of the metacarpals, and you can see deformities of the fingers as well. If we look at the top photograph here, you can see this patient has a severe wrist joint effusion. You can see the bulge in the wrist. And if we look at the lower photograph, you can see what's called a swan neck deformity in fingers 1 and 2. You can see hyperextension of some of the distal joints in the fingers. I'm conscious that rheumatoid arthritis is a very complex disease, and it's probably one of the first systemic diseases that you've encountered in your first year. So I've just included a few sample questions here that you might be asked to discuss in a practical examination.